Okay, so thank you so much for everyone for bearing with me. This is great. Welcome to our webinar. This one is very important. Well, each webinar is going to be really important, but for the workflow, everyone, I hope everyone is going to really get why this one is very, very important in the entire workflow, not just for the workflow, but for the end objective, as you can see it. So how's everyone doing? But this is important. This is actually the required face-to-face consultation to establish candidacy for oral appliance therapy. When it comes to documentation, this is for medicine. And in medicine, we actually have to document each encounter, very specific to the disease that we're treating. Unlike dentistry or internist primary care, where you literally walk in and they do a complete physical. But if they have to do, let's say, a sonogram, that's going to be a different encounter, and that has to be documented very specifically, just for the sole purpose of what the diagnosis or what the working diagnosis is. So when we're treating sleep apnea, especially in dentistry, yes, we're going to be doing the sleep screening in the hygiene room, what we discussed last time. But when we establish that a patient has a high probability of sleep apnea that we want to treat, then we switch over to a very specific sleep apnea protocol. And especially if we're going to be doing medical billing, we have to actually document that encounter as an encounter for the face-to-face encounter just for sleep. We cannot include other diagnoses like dental decay or periodontal disease or anything like that. This is very specific to sleep apnea, and we have to actually establish this candidacy for appliance therapy. So that's medical need. So what we're going to do is we're going to go through a step-by-step of how we go about getting that objective met. So let's start. Thank you so much. Oh, that's so sweet, Ed. Thank you so much. Doing this from his holiday, which is wonderful. Okay, so our mission and our mission for apnea is to really enable dentists to expand the range of services, connect with physicians and patients in a very different manner that they aren't traditionally used to in their typical dental practice, for the sole benefit of the patient's well-being, and in the process actually help their practices do better. As you start to treat sleep apnea and start to see that you're actually making a change in the patients for their life, for a better life, it's quite intoxicating and contagious, that feeling, and patients will appreciate it beyond what you do for them already, because now you're taking their care to a completely different level, from a lifetime care to a life-saving care. So what we've done is we've actually taken all best practices for dental sleep medicine and created this EMR, electronic medical records, and made it cloud-based, so it can be accessible to you from anywhere. And this iEMR is not just internet-based, it's also an intelligent EMR. You may have noticed that you guys have practice management software in your practice that you conduct, your accounting and your data, archiving. But traditional EMRs, traditional practice management softwares, are nothing more than a data warehouse. They just take in data and archive it, and then you can ask the data to be interpreted in terms of, you want dental billing, if you want a report done. And that's all it does. There is no real analytics. These predictive guides for workflow. Let's assume you have periodontal disease. Your hygienist takes periodontal charting. They take a full mat series. You do a clinical exam, and you document all that stuff in your practice management. But the software doesn't really give you recommendations of how to go about getting that patient treated in the most optimal way. It's completely left to your opinion. And the more data you have, in terms of the more education and knowledge you have, the more data points you have, the better you'll be able to decide whether this patient will be best treated surgically, non-surgically. What are the probabilities of of successful treatment outcome if you go one way versus the other way. That's really completely left to you. The practice management software doesn't give you any analytics or any help in a workflow. Well, this practice management software does. So let's go through the steps one by one. So sleep apnea, I say sleep apnea is a terrible, terrible disease. It's a horrible disease. The prevalence is just increasing day by day, and the NIH has stated that by 2025 it's going to be of epidemic proportions, and that's insane because every year the incidence just keeps going up and up and up, and it's actually affecting all sorts of things. We have people who have sleep apnea, untreated sleep apnea. We know that it literally increases healthcare costs, their healthcare costs, and then eventually it has to be passed on to everyone else. So everyone's healthcare cost goes up in premiums and increased, deductibles, because the insurance companies have to make their money and they have to pass it on to someone. So it's everyone. We also know that untreated sleep apnea and sleep deprivation has a 15 times increased likelihood of traffic accidents. That's terrible. And we know that people who are tired and sleepy miss work at a higher rate than people who are alert and not sleepy. So we know that we have literally an epidemic. We have about 60 million people that suffer, and about 50 million are undiagnosed. And that's tremendous. So the opportunity for dental is massive, because when you have 80% that are undiagnosed, and we know that of the 20 that are diagnosed, 3 out of 4 actually refuses CPAP, and 1 out of 4 that actually tries a CPAP. Out of that, at 1 year mark, only 1 out of 4 of those. So 25% of the ones that actually tries it, 25% of 25% actually are compliant at 1 year mark. How much opportunity we have in our practices to help these people. We know that workplace accidents, it costs our GDP tremendous amounts of money, almost 165 billion now. The most recent estimate was 165 billion is what the GDP loses every year as a result of undiagnosed sleep apnea, and that's a lot of money. And no amount of coffee is going to be able to help. And you really can't have people with sleep deprivation just try to make up sleep on the weekends. It's a lifestyle. We have to get our sleep every single day of the required amount of time and required amount of actual, duration of sleep. We can't skip it. Think about this. If somebody ever told you that we have a magic pill that can make you healthier, it can reduce your disease incidence, it can give you a lot of energy, make you more productive, improve your memory, prevent accidents from happening, give you more productivity, would you take that? Would you buy that pill? Well, it's free. It's called sleep, and you don't need to take a pill for that. So it's important that you understand why sleep is very important, and why it's important for your patients, and those patients that don't get enough sleep are at higher risk, and you're able to help them. Actually, you're able to help them where a lot of physicians and medicine has failed because they only have one thing. What? A CPAP. Well, they have medications and surgery, but they all have side effects attached to it. What's the side effect of oral appliance? Really nothing. It's reversible. When done right, there are virtually no side effects to oral appliances. In the webinar number 1, we actually went about how to screen our patients. We talked about the sleepiness scale, but we also know that 60% of patients who suffer from sleep apnea actually don't experience or report experiencing daytime sleepiness. So if we're just solely going based on the Epworth Sleepiness Scale, as a form of screening, then we're actually losing out on the 60% that actually do not fall into that category. So using other means of screening, like a stop bang, which is a very predictable screening methodology, used universally in conjunction with Epworth Sleepiness Scale. We call that SLEEP-SWOT. It has a high predictive value for likelihood of somebody suffering from sleep apnea. We also went over practice-specific marketing resources for those of you who have their practice profile and their practice. You can actually go and take a look at the resources section. All the marketing is there for you, and we can go through that section as well when we go through the navigating the website part of it. And we went over how to add a patient and initiate the treatment process. So like I mentioned, for dental practices, we have a tremendous opportunity, tremendous. So we know that 20% of our adult patients in our practices suffer from sleep apnea, and only, only 20% are diagnosed. So we have the 80% that are not diagnosed. It's tremendous. So for the 1,000 patients on a typical adult practice, we have 160 that are undiagnosed. And of the 40 that were diagnosed, we're dealing with only 15 that are compliant with their CPAP. So that makes us an opportunity. That gives us an opportunity to treat 185 patients. And that's remarkable. And this is life-saving care. And we also talked about last time that how practicing dental sleep medicine, besides being life-saving care, is actually very lucrative and profitable for the practice. And there's nothing wrong in having a profitable practice. That's how you employ people. That's how you're responsible for how many lives and how many families that are employed. So there's nothing wrong with a profitable practice as long as you do it ethically, as long as you do it responsibly, with one mission in mind, and that's for the patient's well-being. I mean, patient's paramount. Patient's well-being is paramount. Everything has to be done taking into account patient's well-being. And if you do those things, there's nothing wrong in having a profitable practice. And as you can see, practicing dental sleep medicine is a lot more profitable than practicing another form of therapy for, let's say, Invisalign. We talked about how single screening is really not very efficient, that a combined scoring is necessary, and how 60% of the patients who suffer from sleep apnea don't actually report experiencing daytime sleepiness, hypersomnolescence, as it's called. So we talked about the predictors of sleep apnea, large mass index, body mass index of 25, large neck circumference. For men, it's 17 inches or greater. For women, it's 16 inches or greater. Nasal obstructions, when somebody can't breathe through their nose, they have to compensate by breathing through their mouth. But realize something. There's an exact mechanism why the nose was developed as a nose to be breathed from. We don't eat from our nose. We weren't meant to breathe from our mouths. So people with nasal obstructions, high nasal resistance, have a high incidence of sleep apnea. Airway crowding, large tonsils, thick uvula, these are all predictors of sleep apnea. Dental crowding, lingually tipped premolars and molars, mandibular tori, they're all occupy space that otherwise would have been occupied by tongue. And when tongue can't rest comfortably in the confines of the mandible, it's displaced superiorly and it rests above the occlusal plane. And when somebody falls back, especially on their back, the tongue falls back because the mandible moves back a little bit, tongue falls back and obstructs the throat even more. So when we have narrow mandibles, retruded mandibles, class 2 mandibular deficiency where you have really a retruded mandible, these are all indications in your practice to really have that conversation with the patient. And looking at all these other factors, because there's no one factor that actually is a predictor of sleep apnea. It's a collective. So you have to actually look at everything and look at the big picture and then derive from there, your working diagnosis. Enlarged tongue, bilateral ridges of the tongue. We had talked about it last time. When the tongue can't be confined comfortably, passively in the mandible, it tries to fit itself in and it presses against the lingual surfaces of the teeth, and that chronic pressing actually leaves behind a depression, which you can actually see as indentations. And of course, as submandibular adipose tissue, the fat below the tongue in the neck is actually, causes the tongue to actually be pushed up as well. And anytime the tongue is pushed above its comfortable resting position, there's a higher likelihood of that tongue falling back into the back of the throat and obstructing airway. So neck circumference, snoring. When patients report that they're snoring, that should be a clue to investigate into the likelihood of sleep apnea. Because yes, you have silent apneics who don't snore and have sleep apnea, and yes, you have people who snore who don't have sleep apnea, so they're not mutually exclusive, right? So, but if they report snoring, that's an indication that you want to investigate a little bit more. Witnessed apneas, if they just tell you that their spouse or bed partner or somebody has told them that they actually stop breathing in the middle of the night, that's a clear indication for you to investigate further. Patients with hypertension, we know that 83% of patients who are drug-resistant hypertension, and overall 35% of hypertension patients, so 35% of all hypertension patients and 83% of hypertension patients who are drug resistance, who have drug resistance, have sleep apnea. People with greater than 25 BMI, 77% of them have sleep apnea. So just when you look at medical histories, when you're reviewing medical histories of patients, this should be a clear telltale sign of you having that conversation and having them and guiding them to move forward with a diagnosis. So how do we get that process going? So the first thing we do is we add a patient in the dashboard. So you actually have your dashboard, and in your dashboard you have this add a patient, and as soon as you add a patient, the patient actually gets an email, on your behalf, that they've been added by you, and they can actually from there click on the links and create their own profile. And when they create their profile, they actually get a separate email where they can use the links to upload health history. They can upload any sleep studies or prescriptions. So if they have a diagnosis of sleep apnea, and they have their sleep study, the results of the sleep study, and a prescription for Appliance with them, they can actually just take a photograph or scan it, then they can upload it right from here into their chart, into their clinical chart. They can fill out their medical history right from here. And these are all form letters that have been generated by our system on your behalf. So they're all branded to you and your practice, and you don't have to do anything. And anytime these letters are sent out to the patients, you're actually blind CC'd on them. So you also are aware that a patient has been, let's assume your hygienist added a patient. Well, guess what? If they forgot because they have a busy day, you will get an email notifying you that a patient was added. If the patient added themselves independently because they found you from our website and they wanted to have that consult with you, then they add themselves as a patient, they fill out their medical history, you get the email notification that a patient was added. The patient added themselves to your dashboard, for you to visit the dashboard to add them on, to actually accept them as a patient. Because you want to know what the medical history is before you get involved. So we have that. And then the patient actually has to go through this very simple screening methodology. So it asks the patient simple questions. Or you, if your hygienist is entering the patient into your dashboard, if the patient has been diagnosed or suspected to suffer from sleep apnea. If that's the case, or no, they don't suspect the patient suffers from sleep apnea, but if they snore or experience daytime sleepiness, because the workflow is different. Also, the workflow is different if they say they have a sleep study, or if they have dental insurance, or they have medical insurance. So depending upon how the questions are answered, the workflow being dynamic will then ask the next appropriate question. So it's very targeted. We don't like to waste anyone's time. We don't like to ask questions that don't apply to someone. So we'll ask qualifying questions beforehand. And if the answer is not applicable or a no, then the next series of questions that would be in line are not available to be, we don't even ask them. So it's literally very targeted and very specific. It's a very dynamic workflow. So once a patient has actually completed their patient forms, in your dashboard, in the patient's chart, you can go and visit and select their patient forms. You can actually review them. And right from there, you actually also have, so right from here, you actually have the ability to actually access your doctor forms, any letters, prescriptions that they uploaded, like the sleep study, prescription of oral appliance, let's assume they were referred by another dentist, a dental colleague who happens to be a member of Apnea, but just doesn't feel comfortable treating a patient and wants to refer them to you. And so, and they already have a panoramic X-ray or full mat series or ortho series photographs that they've taken. Well, they can actually upload them into their patient's chart and then refer the patient to you, and you have access to all that information in your dashboard. So it makes it easy because you can actually access all the previous records right from within your dashboard. So when we surveyed 1,000 dentists, there were 6 barriers, and we discussed some of them last time. The 6 barriers to implementation of dental sleep medicine. Why dentists don't want to implement dental sleep medicine in their practice? The number one reason was lack of education. They just don't know much about it. It wasn't taught in dental school. It wasn't taught in the residency. And of course, the screening is not very predictable. There's a lot of false false negatives and false positives. It's just not a very good, the way things are done, or not very good way. So if you just use an Epworth sleepiness scale, you're missing out 60% of the population that otherwise needs treatment. And of course, the complete subjective and trial and error methodology of guessing where to start the bite and then how to titrate it afterwards, completely arbitrary and subjective, of course. And when you do something so by guesswork, how effective will that therapy be? Not very. So if you practice that way, then you have very inconsistent oral appliance therapy efficacy. Then we also have a very fragmented clinical administrative systems, right? So there is no real practice management software that's this comprehensive. There are the practice management softwares, but they don't have any analytics built into them. They're just data warehouses. And of course, medical billing. Dentists don't know how to do medical billing. So our software actually does it for you. And the next webinar will be dedicated to medical billing. So I would really encourage you to have your team members be on board with that one, which will be on May 7th. So interestingly enough, I'm going to go ahead and get this done because it's very important when we do the sleep screening to understand why sleep screening, it has to be documented a certain way. Because the CMS, the Center for Medicaid and Medicare Services, actually came out with a position paper not too long ago, with actually put in, the requirements for Medicare and private medical insurance billing. And it says you have to, and they can audit claims any moment, at any time. And if you don't have the required necessary documentation and in the right sequence, they can actually deny a claim, and they can actually fine you. If a claim was paid, you have to pay it back with a fine. So it's very important that you pay attention. But nobody expects you to remember what the sequence is. We've done it for you. So all the forms that you'll be getting as part of your workflow are in an exact sequence that is required from a compliance standpoint. Okay? So as requirements change over time, we are aware of that, and we program our systems. So when you come back the next morning and you enroll a patient into the workflow, you just continue with the workflow and not realize that it's been changed. So we take care of that from the back end, so you don't have to worry about it. We just need for you to take care of your patients. We don't need for you to worry about anything else. That's it. That's a lot to worry about by itself. So we don't need to, we don't need for you to worry about any more than what you need to. And so, so yes, dentists can bill for oral appliance therapy. It's in their position paper. Doctors, dentists, and it's interesting. Nurse practitioners can as well. Physician assistants can as well. So imagine, if they can, so can you. So can podiatrists and optometrists. They can also bill medical insurance. Don't know why they would be doing oral appliance therapy, but yes, they can. But anyways, you have to have certain things. You have to have proper documentation. It's an absolute must. You know, you have to provide the insurance company in the event of an audit, which more and more people will be. From what I'm told is, as we start doing this more and more, things are going to be red flagged even more. Just like anything else, you know, if you do more crowns than what the norm is in your area, you know, the insurance company is going to come in, you know, knock on your door and say, we need to audit your records to see if those crowns were absolutely necessary and required. You know, this is no different. This is no different. So we need, just like you maintain really accurate records, and you do due diligence, you take the x-rays, you chart everything, the existing and all the diagnostics, you document and you archive, so you can actually bring them on at a moment's notice. The same way we've done that on your behalf. You know, medical record documentation, you don't have to worry about it. Just continue with the workflow step by step. You know, this is very important. The face-to-face examination for that specific diagnosis. You know, like I mentioned, I started mentioning, if you identify a patient within your hygiene practice and you add them into your chart, into your dashboard as a new patient, and you want to continue with the workflow, and you have to document this face-to-face. That's very specific to sleep apnea, and that's what the sleep screening form is. You know, proof of medical necessity, which is, you know, a sleep study has to be done with a firm diagnosis of sleep apnea, and the certificate of medical necessity is the prescription for oral appliance. That too has to be provided to you for you to be able to do the therapy. So it is required, and like I mentioned, in your dashboard, in the patient's chart in your dashboard, you have a very specific area where all those things are archived. So you can actually, you know, log into that patient's chart and download them to provide. And actually, next time when you see it, in the next webinar, it's actually they're prompts that will prompt you to download them at the right time. So you don't have to think about when to download them. As part of the workflow, you will be prompted at the right time to download necessary forms, and you'll have clickable links just for that form. So it's not like, you know, download forms and then it's left up to you to interpret or determine which forms. It'll actually tell you which forms, and then actually the links will take you directly to those forms. So it's very intelligent from that standpoint. And the coding, you know, in dental we only have one coding, which is the current dental terminology, CDT codes. We are not required to provide in diagnosis code. So if you're doing a crown, we don't have to, there is no diagnosis code for, you know, the cusp fractured below, you know, the height of contour, or there was gross decay, or it's after root canal. There is no diagnostic code. We actually just have to provide evidence of that with a photograph or x-rays. But in medicine, we actually have their codes called, you know, International Classification of Disease, ICD codes. They're diagnostic codes that actually justify the procedure that you'll be doing, you know. So they both have to be in conjunction with each other. So you have to provide both, but we don't expect you to remember anything. The system does it for you. But just remember, you have to, you know, you have to provide both, but we don't expect you to remember. You will actually see it next time at the next webinar, how the system actually does it on your behalf. So here we are. So we have sleep screening exam. So when you do the sleep screening, before the patient forms was a pre-examination form. The first form in your dashboard that will appear is a sleep screening exam. And this is where I'll actually change to a different browser so I can actually go live so you can see it. So the patient completed their pre-examination forms. You can have, if you added the patient, like I mentioned, in your from your hygiene room, you can just give them a tablet to fill out this form. Once they've completed it, once somebody completes a form, it actually turns green, and there's a little eyeball because now read only. And the doctor forms is in red because you haven't completed it yet. So the sleep screening is the first one. So hang on. Okay, so here, this is the form that needs to be documented as the face-to-face encounter. You have done your, so you actually review the sleep screen, the Epworth Sleepiness Scale that the patient completed, so you know what their, you know, what their sleepiness, the drowsiness score is, the vital signs. So your hygienist probably took vital signs, the blood pressure and pulse, as part of their normal, recare program protocol. So let's just say it's 110/70, and the pulse is 78. The patient already completed their height and weight in their pre-examination forms. We can say it's 17. The patient is a habitual snorer. It reports to choke most nights. Now, this could also be the patient has 110/70 because they're controlled hypertensives. So, has hypertension? Yes, and they are on medication. That's why their hypertension is well controlled. So, just imagine if they didn't take their medications, what would their blood pressure be? Okay, so oral examination. We talked about this, that that we have to have a minimum of 8 teeth per arch. That's 4 teeth per quadrant. So do we have this? Yes. Do we have a TMJ? The patient's not complaining of TMJ, great, or severe TMJ, because there's this actual triad, the pain triad, where 3 out of 4 patients who have sleep apnea actually report, waking up in the morning with headaches. The same people are grinding at night, and as a result, there's tremendous amounts of occlusal change because teeth grind down over time. And as teeth grind down over time, the occlusal scheme changes, and the way the condyles are positioned in the fossa changes, and that can actually create TMD. So it's not uncommon for you to have patients who have sleep apnea also bruxing and complaining of jaw pain and headaches and myofascial pain disorder. We know that we basically look and make sure that they have good periodontal support. The last thing we want is to initiate periodontal oral appliance therapy on loose, chipped, cracked, broken teeth, swelling, swollen, inflamed gums. We want to be able to take care of that stuff. So at that point, we just literally do our basic oral screening, and we then decide, is the dental status adequate for appliance therapy? So pretty much use the same guidelines that you would for, let's say, Invisalign. You just similar to, you're not doing Invisalign on patients that have chipped, cracked, broken teeth with periodontal disease, or dental disease, or periodontal disease, or some other kind of oral condition. The same exact way. You don't want to do this. But what a great motivational tool this is for you to tell a patient that you are not a candidate for oral appliance therapy with all these conditions occurring simultaneously. We have to take care of them first and then do oral appliance therapy. And especially a patient who doesn't want to try a CPAP and understands that without this therapy, they're going to have a miserable day and a poor quality of life. What a great motivational tool this is for them to continue and complete all that undone, untreated dentistry that's still sitting around waiting to be treated. And they want to get it done fast. Okay? So once you're done, or if they have good dental status, dental health, you just click that. Then basically, your assessment is your assessment based on the review of medical history, oral examination, and in this case, there was a sleep study, or not, the diagnosis given by, a doctor. You can just say, click, 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 CPAP intolerance affidavit if the patient was CPAP intolerant. Any other conditions that might indicate, but the patient didn't indicate any other conditions, so that's why it's not a bit, we're not able to click it. So here we say, based on all that stuff, the patient is a candidate for appliance therapy, right? And we can say it's essential hypertension, fatigue. We have headaches in the morning. We have all these conditions, shortness of breath. And if the patient's not a candidate for appliance therapy because they have insufficient dentition, the patient should attempt a CPAP first. Let's assume, they have such severe sleep apnea, and our job is to counsel them in the right appropriate therapy. And by all means, based on practice parameters and guidelines, for anyone that has 30 AHI or more of AHI, which is categorized, which is categorized as severe, they should try CPAP first. You know, it's the right thing. CPAPs work 100% of the time. They cure somebody of sleep apnea as long as they wear it. For the time being that they're wearing it, you can actually eliminate sleep apnea. But the problem is, as we know, that 3 out of 4 patients who are prescribed a CPAP don't even want to try it, and only 1 out of 4 that actually did try it are compliant with it, you know, at 1 year mark. So, and new Medicare guidelines are going to be coming out, which actually are out, which I will actually release sometime this week, which really brings caution to this whole thing with CPAP first. And you will actually, you know, get that. Here, the patient is a good candidate. We've done that. Now, let's assume the patient says, I don't want to move forward with treatment. I just don't care. I just don't want to wear an oral appliance. I don't want to wear CPAP. I really don't care, you know, and that's fine. But we have to document that refusal of treatment. It's very important that we document that refusal of treatment, because just because we say, okay, fine, you know, that's fine, you know, but realize you should get it treated is not good enough, because next week or 1 month from that point, if the patient somehow falls asleep behind the wheel of a car and hurts themselves, or worse, hurts someone else, and some smart lawyer says, oh, let me just look at your medical history. Oh, look, you were suspected to have sleep apnea, but you know what? And yes, I was, and you know, my dentist actually mentioned to me that I should be treated for sleep apnea, but I refused. Really? You refused? Is there a refusal of treatment somewhere? Well, if you don't document that refusal of treatment, well, guess what? That's not good enough. So what we have done is we've actually done that for you. So if you indicate that the patient refused treatment at any stage, guess what? All of a sudden, you know, the patient is actually told the complications of untreated sleep apnea and sleep deprivation, including but not limited to. It's like a laundry list. And this is really all documented. This is all reported, you know, complications of sleep apnea and sleep deprivation, you know. So this actually is there. The patient is then asked to sign this form. You sign it, and there's a witness. So we always have to have a witness sign it. So it doesn't necessarily have to be somebody related to the patient. It could be one of your dental assistants or administrative assistants, the witness. And when you actually save and continue this form, especially if the patient refused this treatment, this entire encounter, this entire form, including this thing, gets emailed to them. Just like how patients get these emails, automatic emails, when they complete something, or if they have to complete something, this actually goes to them in their inbox, email inbox. And this also gets archived in the patient's chart on our platform. So now you've actually advised the patient of all the things that can happen as a result of untreating it. You know, so you've done your job. You've met your ethical obligation, you know, to advise the patient of what can possibly happen if they don't move forward with treatment. Ultimately, it's their choice, right? It's their choice, but it's also your duty to advise them. So what we've done is we've taken care of that, you know, on your behalf. But let's assume that's not the case, right? The patient wants to move forward with getting a diagnosis. So you would like to see the patient in, let's say, 1 week, 4. You know, you want to review sleep study. Okay. And depending on how much time you spent, you know, in medicine, everything is based on time and complexity. So if we spent 20 minutes, that's a level 2. You don't have to know what the qualification for level 1 exam is, level 2 exam, level 3 exam is. We've done that for you. So all you have to do is just kind of just say, you know, how much time. Unlike dental, where it's limited, oral, or comprehensive, or detailed, which is very subjective. What qualifies for that? Here it's time dependent. So here, treatment plan, we are going to schedule the patient for a workup, you know, first. And once we save and continue this, you know, you may have noticed in the past workups, if you, for whatever reason, omit to enter a particular field, the system will actually give you 1 chance to review it, all the fields that you've missed. And if you unintentionally omitted them, you can go back. You have one more opportunity to fill it out. And if you intentionally omitted it, you can just continue to skip it, right? Make sure that you didn't leave anything out. Save and continue. And the next step is what? A financial agreement. That's your firm financial. A financial agreement has to be in place before you incur any additional expense or time into treatment. So here you can actually develop a treatment plan. You actually can define what you want to do. You want to do oral appliance therapy, and how much do you want to charge for that oral appliance therapy? Whatever it is, let's say it's $1. It doesn't matter what it is. You define it for yourself. We just give you a suggested fee. We're also going to do, let's say, a full mat series, and we can charge them $1. Diagnostic, we're going to do a CT scan or a PAN, whatever it is. So as you can see, you can just continue adding, whatever you'd like. You can continue doing this, and at the end, it literally calculates, what the fee would be, the total fee would be for your service to that patient for the entire, therapy. At that point, you, just like anything else, the patient is advised of what the case fee would be. And like anything else, because you're not, well, some may not be, but for most of you are not participating with medical insurance. You're not in network with medical insurance. So you're not really obliged to be held to their fee schedule. So, if you were participating with their medical insurance and you were in their medical insurance network, then you would accept assignment of benefits. And if that's the case in the medical insurance CMS form, when the time comes, if you indicated in your profile, when you set up the profile, when it asked you, if you participate with medical insurance and you indicated the medical insurances that you participate with, if in the CMS form, if the patient has that particular insurance, then in the CMS form, where it says assignment of benefits, it would automatically check yes, because you're a provider. So the system actually is pretty intelligent and figures things out based on the input. So it's so critical for you to actually have a very accurate profile. So all the information in your profile should be really, really accurate, because a lot of that data is being pulled for future forms. So if you have an error in there, it's going to throw errors all over the place wherever that field is required. Okay? So I would ask you go back and just go back to your profile and look at every little thing, make sure it's accurate, because that's less work for you later on, as you will see. So you have this conversation with them. They said, fine, you can do a financing plan if they don't have the money, which is Care Credit or whatever other third-party financing program you do. So you just indicate that. Now, at this point, the patient says, wow, $3, that's a lot of money. And, I don't want to move forward with it. I just don't have it. And that's completely fine. They can refuse treatment at this point, and the same thing happens. But if they want to move forward with it, they still have to, sign the form. You have to sign it. The witness has to sign it. And when you save and continue this, this exact form also gets emailed to the patient for their record. So email goes out with that, to them with this as an attachment for them to archive in their own, files. So we do it for you, and we archive it for you in the patient's chart, and the patient also has the ability to archive it themselves. So we just do that. Witness names DA, relationship DA, witness signature, hit and continue. Again, that's done. So as I mentioned, this is actually the email that the patient gets for the financial agreement with the attachment. So you realize the last time the only option that was available for you was a sleep screening exam. Now that's complete. The next form shows up. So you don't get a whole laundry list of forms and you have to figure out for yourself, which form do I fill out first? It actually literally gives you the form that you need to complete first. If the patient has medical insurance and the patient indicated in this case that they have medical insurance, then the next form will be the phone pre-authorization for medical insurance, which we will cover next time. We have your dashboard. We have the resources section, which we should really, really have our team members go through. Here we have the stop bang questionnaire, the Epworth Sleepiness Scale. I would strongly advise you have them downloaded and distribute them to your patients. Have them ready to in your hygiene room, the stop bangs for the hygienist to fill out. We have marketing letters, announcement to patients for oral appliance therapy. We have OSA fact sheet. What is oral appliance therapy? We have announcement to MDs introducing oral appliance therapy. What is oral appliance therapy? Most physicians don't even know what oral appliance therapy is. So announcement to sleep physicians, to physicians for partnership, asking them for referrals. So all these forms, are all branded to you, and especially this form is quite remarkable because it's an announcement to sleep physicians for partnership and request for prescription for oral appliance. So this is a form that you can actually just type in doctor's name, Dr. MD, and when you print this form, as you will notice, in our pursuit to, and you guys can read this, I'm not going to waste time reading it, but it's literally telling the physician that you have credentials. You went through an actual course to get certified to treat this process. You're just not a regular dentist who took, who just thinks that taking a bunch of impressions and an arbitrary bite and having a lab do everything in terms of fabricating the appliance is the way to treat a patient. So this is a very important letter for you to actually just start networking with your sleep physicians and introducing them to the fact that you actually have more training than most dentists do, and that you actually have an exact way of treating patients that is predictable, that's scientific, that's been proven to be efficacious, okay, and it's branded to you. And you can actually, if you practice in multiple practices, you can actually, as you can see this, you can actually choose, and this brands to whatever practice you're in. If you happen to be in multiple offices, if you set up your profile for multiple offices, it will capture that data. That's why it's so important for you to really have a very accurate profile. So here it is. You send this to them. They actually get this. They can print it up. So if they have a patient, they can actually type in the patient's name. They can write the patient's name in that's been diagnosed with sleep apnea but has failed the CPAP. They can write the patient's name, date of birth, and they can actually send you this prescription. And they can write in their name. So they actually can use this as a prescription to send you patients, if they're not part of the apnea physician membership. So they can actually just keep doing this all day long. So how easy is it that you've actually given them a prescription that all they have to do is just fill in. They don't have to think about what to write, what to do. It's all here for them. Oral appliance therapy, the code is right here. It's a custom fitted oral appliance for treating OSA. It's made specifically for a patient. No other patient would be able to use it. It involves substantial work to produce, usually by a specialized lab like SomnoMed, and may involve the incorporation of some prefabricated components, jack screws and whatever. But it tells them what an oral appliance is. That it's not just something random that you took off a shelf, or it's boil and bite. This is actually custom made. It's very targeted therapy that's custom made for that individual patient. So this is that form, and it's in your in your dashboard. In marketing letters, you have a bunch of FAQs. You have videos. You can ask questions. You have Cato. You can start a conversation with Cato. You can ask Cato questions. Cato will point you and guide you and give you the answers. And if it doesn't have an answer, because don't forget, it's artificial intelligence, we're training it like an infant. When an infant is born, they're not very intelligent. We have to nurture that infant. We have to care for that infant. We have to educate that infant. And one day they can become, Einstein. Even Einstein at 13, 14 was a completely bumbling idiot. Couldn't tie his shoelaces. So it's our job to train Cato. So the more questions you ask, the better it will learn, and after a while it will be self-sufficient. That's our ultimate goal. We have brochures and posters, and thanks to Ray, who has a significant Spanish population, what we did was we actually had them made for in Spanish. So we have posters, we have brochures in Spanish, So for your Spanish-speaking population, you can actually, have them available for them, and you can actually just literally, they're print ready, so you can actually just send it to a printer, and you can blow it up as big as you want. They're high definition, so you can actually have a 6 by 8 feet if you want for your hygiene room, or for a billboard outside your building, or just literally for a hygiene room, have a 3 by 2 poster. These brochures are ready for you to download. Just simply download and have them available for your patients. You have, at any moment in time, you have a new team member that comes and joins you. Just literally, put them in front of a computer, put on the team training, have them watch it. So no longer do you have to have your team members take time off, go to go out of town, away from the practice. And same thing with you guys. Anytime you want to revisit your modules, you can come back here into the certification, access it, and review it. You can do it. And the great part about this is, if we decide that there's a significant change in the way in the way, let's assume, pediatric sleep medicine is practiced, right? Then all we do is we literally behind the scenes edit this entire module, add stuff to it, change things around, and put it right back. And anytime we update any module, you guys get an email alert saying a particular module has been updated for you to log into your dashboards and review it. And that's forever. That's indefinitely, and no extra charge. It's completely free. It comes with your one-time certification charge, So we have that, and your practice profile is paramount. And as you advance and you want to get more, then you can actually take the board review course. And that's our next webinar on May 7th, Tuesday. It's how to obtain medical insurance predetermination and complete a medical insurance form. So we hope that you guys can make it. So thanks, Peter. Thank you so much. So now, I know we started a bit late, so I apologize, but we're on time for our Q&A. So let's have it. So the first question is, hang on, Pankaj, we would like a place to enter clinical notes in the software. Is there a reason why, sorry, you have not included a place to do so? No, you actually can. There's there's on the bottom of all the pages, there's a little line that says other, and that's where you can actually enter your clinical notes, and you can keep adding as much as you want, each line by line. So you get the first line is available for you. Once you complete typing in that line, then the second line will appear for you to complete. So you can actually add notes as you wish. I hope that answers that question. The second question is, what if the patient doesn't want to sign the refusal form? They don't have to sign anything. You just document in that form, or you document in the chart that patient refused to sign the form, and that's fine. You can actually not have the patient sign it, but still send that unsigned form to the patient. So you've done your job, you've actually sent it, and in there you can actually write the patient refused to sign. So thank you, we didn't realize that. Okay, no, that's fine. As you start to use this, so think about a software. This is a brand new software for you. You guys aren't used to documenting things in this manner, because you just were never taught. So the more you use this software, the more you'll start to understand the subtle nuances that it comes with. And like anything else, the more you use it, the more familiar you will become, the faster you will navigate through it. It's just think about all the different features in Microsoft, Office Word, using the different tabs. How do you insert something? How do you draw something? How do you import something? It's just a matter of, you just have to use it. Once you use it one or two times, you then, start to understand how do you manipulate the system. So it's just that. It's the more you use it, the better you will become at it. Please update on Somnodent Appliance. Yes. Oh, hi, Ed. Okay, yes. So we are making great progress. We're just waiting on Somnodent Corporate to give us those updates. And I will follow up with them first thing in the morning. I promise. And I hope I can have something for you by the end of this week, because I know I've gotten so many requests on Somnomed, on Somnodent appliances, and they've got a tremendous range, and they're constantly coming up, and they're going to be coming out with some amazing ones too. So I really want our members to take advantage of all the technology that they're putting into their appliances. You know, it's one thing to have an appliance that's well made and done right. It's another thing to actually add the analytics and have the right bite, because the two things combined make a big difference. So the next question is, does the patient have to be CPAP intolerant in order to get a sleep appliance for mild and moderate? Great question. No. So practice parameters and guidelines for the American Academy of Sleep Medicine say no. The first round of therapy for mild and moderates can be an oral appliance. Only for the severe ones, they have to document intolerance or failure. Yes. So the next question is, can we go straight to oral appliance before CPAP? Yes. For mild and moderate, absolutely. Absolutely. You know, and actually the interesting part is I'm going to actually expand on that answer, is realize something. The entire ASM guidelines on oral appliance therapy for mild and moderate and severe is based solely on the AHI, solely on AHI. They've just said, given a guideline saying anywhere from literally 5 to 29 AHI, which is mild and moderate, and the 30 is severe. What makes 29 and 30 so special that one can have an oral appliance and the other one not? You know, so this one thing, and I hope I can present this. I actually presented this lecture this past weekend in Phoenix at the Sleep and Breathing Academy conference, where I actually broke down why just the sole determinant of qualification for oral appliance being AHI is completely inadequate. It's AHI by itself cannot be the sole determinant. It's unfair to a whole bunch of patients, especially when we know that 3 out of 4 that are severe, that were prescribed a CPAP, will actually refuse it from onset. And then why do they have to actually go through that trial period when we know that 25% of them, 75% of them at 1 year mark will be non-tolerant or incompliant? So if we know, and we know what those factors are, because as part of our workflow, we know, we've done enough research to know who's going to be a better responder and who's not going to be a better responder with our appliances. Why not give the patients the option, one or the other, from the very beginning? You know, and if we have that workflow, that would make life a lot simpler. Okay, so next question is, will you have this webinar available to view later? Yes, all our webinars are going to be archived and available on our YouTube channel. So we actually have a channel on YouTube. We will also be sending you guys emails embedded with the video. So give us some time to kind of edit. We want to be able to kind of edit out the beginning period where we were having some technical issues. But yes, all these will be made available to you within a few days. Did you meet with the WatchPat rep? I did. We didn't have enough time, so it was a pretty crazy weekend. I got there Saturday morning at the conference. Actually got there at 1 o'clock, lectured at 3 o'clock, and I was back out. So I did meet him, and I hope we can do something with them. Ray, that's on my to-do list for this week. A wonderful person. Thank you. Thanks for the introduction, Ray. And thanks for everything you do, really. Okay, next question. Oh, you're welcome, Ed. My pleasure. Miss you. Miss your emails too. I wish you would CC me on them. Love reading your emails and your cases. Okay. Thank you, Dale. Oh, thanks. Thanks, Dale. Yeah, it's pretty intuitive and very intelligent workflow. So it all there to help you, streamline, your clinical time. And as you noticed, a lot of that stuff can be done by your assistants and your hygienists. It doesn't really require tremendous amounts of your time. So I would strongly advise you that you have your team visit the webinar, and the first one, second one, and any new team members come in, just literally plop them in front of a computer and have them view it for an hour. And even if you have to buy them lunch for that time, big deal. Head to sleeptest.com. They send home sleep tests to patient and a board certified. Yes, we have heard of sleeptest.com, but what I would and that's fine. You can send it. You can send the patient literally. You can send them to any home sleep study company, but visit them. And sleeptest.com actually charges you the dentist, a sign up fee. I think of $1,000. That's a setup fee. And then they charge you, the dentist, I think it's $450 per study, where they literally send the sleep study out to the patient, read it, and send it back. Send you guys the results and the prescription. So imagine for your practice, there's an initial setup cost of $1,000 just for their portal, because it's their portal. So you have to kind of enter the patient in their portal, and they manage all that stuff through their portal. But for that, it costs you about $1,000 to set up. I think there's some kind of a monthly fee, but it's about $400 or $450 per test, versus the contracted fee with the company that is our preferred sleep test does the exact same thing. But the portal, there is no setup fee because you use our portal. And as you notice, there is no fee for our portal for that. So, and the contracted fee is $200. So think about it. With Apnea, which is the home sleep study company, it's a nationwide company. They have physicians all over that can read per state, and they have their own dashboard on our portal. So you can actually send them the prescription electronically with a click of a button. They manage the sending out the home sleep study to the patient. The patient sends it back to them. Their physicians read it. They upload the report and the prescription right into the patient's chart, and you get an email notification that that was done. There is no lag. It's real-time alerts. So as soon as their physician reads it and uploads it, it gets uploaded into the patient's chart, and you get the email that a sleep study was uploaded. Okay? Oh, thanks, Philip. Miss you. I really do. Will we get an invite to the next webinar? Absolutely, you will. Absolutely. This is your new email for those of us that have further questions. Yep, feel free to shoot me emails here, Chris. Absolutely. Where can we find more info on Apnea? Apnea, you can actually Google Apnea at all. I mean, it's Apnea is one word. It's APP-NEA. So unlike Apnea, which is us, APP-NEA, because it's a play on words, where it's a cloud-based app for apnea. That their company is just Apnea, APNEA, So you can Google them, and you can actually ask them to send it independent of us, but then you'll end up paying more and have to do a manual process. Where's the link to Apnea on your website? We don't have a link for Apnea on the website. It's part of the workflow. So when the time comes for you to refer the patient for a sleep study, the options will show up to refer them for an in-lab or an at-home. And for those of you who actually do, who actually dispense or give the patient the sleep test, the home sleep study, that option is also built in there. But it's part of the workflow. So they, once you send them a prescription, they handle everything, and they'll reach out to you to set up that account for the billing and all that stuff, independent of us. Well, if you have any further questions, guys, please send me an email. I'll be happy to help. Okay? Don't be shy. Okay. Thanks for your attendance and for for really all of your support. And And that's what keeps me going, knowing that you guys are behind me and you guys are excited about this. It gives me the motivation to continue and continue to help you guys so you can help your patients.